Hello and welcome to Paramedic Pearls. In this episode, we're going to talk about STEMI. And I want to give you a snapshot about a scoring system that I came up with that I think is really good. In fact, some are even calling it genius. And I want to talk about something that I learned in my own practice recently and just give a couple of pointers around STEMI. Now, we developed the STEMI system in LA County about 11 years ago, and I was initially a naysayer, and boy was I on the wrong side of history on this one. Performing a 12-lead EKG in the field and routing the patient to the right facility and really greasing the wheels to get that patient to the cath lab and get their heart reperfused is absolutely life-saving. And in addition to saving lives, it also saves myocardium, which really reduces morbidity and helps return people back to a normal level of function. In order to do that, you need to understand a little bit about what happens at the hospital when you call and tell them that you have a STEMI patient coming in. So realize that it takes a village to run a STEMI case. It's not just the emergency department. They have to activate a whole team to open up the cath lab, get the cardiologist coming in and everything. So those teams often have to drive in from the outside. Sometimes during the workday, they're all there in the hospital, but often they're not. Or they may have another patient on the table that they need to expedite clearing that room and getting ready for your patient. So the sooner that they know that they have a STEMI patient coming in, the absolute better it is for the patient to get through into the cath lab fast. So the way that we do that is get a high quality 12-lead EKG in the field whenever possible. I know sometimes the patients can't sit still or are profusely sweating, but get a good 12-lead EKG in the field and transmit it to the STEMI center. It's much more important that you transmit it than you attach it to your EPCR. Yes, I want to see it on your EPCR, but transmitting it to the hospital before you even make that notification allows the hospital to look at the 12-lead EKG while they're talking to you on the phone. And cases that are slam dunk STEMIs, they should be activating their STEMI team long before you ever step foot in the hospital. If you don't transmit the EKG and you walk into the hospital with that EKG, that time that you were transporting is all lost to the patient, and it just delays everything, which can affect the patient's outcome. Now, let me tell you about a new scoring system that you can try, and it's called the Kazan score, or I try to rename it the Focused Assessment for Reperfusion Therapy score, or the FART score, but unfortunately that didn't gain traction. People seem to like the name Kazan score. It's a 3-point score. Point number 1 is your interpretation of the 12-lead EKG. Do you believe you're looking at a STEMI? Point 2, does the machine believe that what you're looking at is a STEMI? Our computer algorithms in the Zols are very sophisticated. So if you and the machine agree, it's a very high likelihood that you're looking at a real STEMI. The third point is for the patient presentation. Is the patient's presentation consistent with STEMI? In other words, if you have a patient with retrosternal chest tightness, shortness of breath, nausea, and sweating, that is a definite yes. If you have a patient who stubbed their toe and for whatever reason you chose to do a 12-lead EKG, you probably wouldn't give them that point. In that 3-point scale, if the patient meets all 3 points, that should be a slam dunk field activation of the STEMI team. If the patient meets 2 out of 3, very likely this is a real STEMI, and the patient definitely needs to go to the STEMI center, and they should consider activating just based on your assessment. If it's a 1 out of 3, that patient probably should go to the STEMI center, but they probably should not be activated until the emergency department team has the opportunity to reevaluate your patient. If it's a 0 out of 3, it's not a STEMI, it should go to the most appropriate receiving hospital. Now, one last thing that I learned recently from one of my colleagues at Little Company of Mary, and that is when you have a patient that's having a STEMI, put Zoll defibrillator pads on that patient. I had a patient, and then I saw another one at the hospital very shortly thereafter that my partner was managing that flipped into VFib very, very quickly. Unfortunately, my patient, we were unable to resuscitate. The other patient, they were able to quickly defibrillate and send off to the cath lab, and he had a good outcome. Just know there's a small but very realistic possibility that no matter how stable and good your STEMI patient looks, their myocardium is very irritated and irritable, and it can flip into VFib. It is best that you have those pads in place, and if you notice that that happens, just charge it up and shock them. If you shock them right out of it, often they'll wake right back up and have no recollection of what just happened, but you can absolutely save their life. The longer they're in VFib, the less the chance you're going to shock them back out of it. So, with all that said, these are your STEMI pearls for the day. Enjoy, be safe out there, and please send me your questions.